Great, thank you. We'll give everybody a moment to get from the last session before diving into our own on sexual orientation and gender identity data. I see slowly the numbers are coming up, people coming in. We got away from our fearless leader, Dr. Michael Pasha-Orlo, who strong-armed me into doing this. And just to get an idea, do we have an idea how many attendings we were expecting?
Well, it's hard to know in a virtual meeting. There were
Yeah.
235 people registered, but the last session I was just in had 49, I think. And there's another session competing with this one too. And
Okay.
so I don't know, but it is being recorded, and it's going to go out to everybody who registered, and then also will be on the website
Okay.
forever.
In the interest of acknowledging that we're all humans, I imagine things have been back to back. We'll give it another minute or so for people to log in and kind of move over to this session. And then we will go ahead and get started. But I hope everybody's having a wonderful day. I know this is the last day of the conference. Thank you for spending some time with us at the end of a busy day. And I think we're the session right before closing. So thank you for joining us. If any of the speakers, this is the time to get coffee, water, get caffeinated, hydrated, whatever you need at this hour of the day.
I think you can. I think you can start, and
Okay.
I'm just going to lurk here a bit, and looking forward to it.
Great. Well, no pressure. So again, thank you everybody for joining. This is our session on sexual orientation and gender identity data collection and its relation to health literacy and broadly health in general, to be perfectly honest. I'm Carl, he, him. I'm a primary care doc, a clinician investigator at Boston University's Chouanian and Avedisian School of Medicine, and the research lead in our Gender Care Center, which focuses on the provision of gender-affirming care for adults. I have a wonderful panel that I was fortunate to wrangle into talking about this. We do not have slides. We really want this to be a discussion. There's going to be a lot of questions that we've prepared that we want to kind of lay the groundwork, but we want to make sure that you as attendees have an opportunity to ask questions about this. I will do introductions, spare everybody a little bit of time around that, and then we will dive right in. So first, I'd like to start with Dr. Kellen Baker. Callan, wave, thank you. Dr. Baker is the executive director of Whitman Walker Institute, which works to create healthier communities and advance health equity for all through person-centered research and innovative policy solutions. The Institute is affiliated with Whitman Walker Health, a federally qualified health center with more than 50 years of service to diverse communities in Washington, D.C. and beyond. Callan has been a frequent advisor to the government and private entities on broadly LGBTQI plus health and health equity for more than 15 years, and he holds appointments as affiliate faculty in the Department of Health Policy and Management at the George Washington University and the Johns Hopkins School of Public Health. Callan did receive his PhD from Johns Hopkins, where he was the Centennial Scholar and a Health Policy Research Scholar, has an MPH and MA from the George Washington University, and a BA with honors from Swarthmore College. If I remember correctly, that one is in Russian?
Astrophysics.
Astrophysics, that's correct.
And Russian.
Show off.
I have problems making up my mind.
Understood. Christina Dragon. Christina, please raise your hand. Christina Dragon serves as the measurement and data lead in the NIH Sexual and Gender Minority Research Office and part-time supporting the HHS Office of the Assistant Secretary for Health as the SOGI Data Implementation Specialist. Previously, she served as the Sexual and Gender Minority Data Lead in Medicare's Office of Minority Health and as the data analyst for the Healthy People 2020 LGBT health topic area at the National Center for Health Statistics in the CDC. She serves on the Sexual Orientation, Gender Identity, and Sex Characteristics Subcommittee of the Federal Committee on Statistical Methodology, and in 2022 led the subgroup on SOGI data for administrative forms for the Interagency Working Group on the Federal Evidence Agenda on LGBTQI plus equity, which was published in January of 2023. Besides SGM data, Christina also worked on 2 public health emergencies, the Ebola response in 2015 with the CDC and the COVID-19 pandemic response, while working to protect worker safety and health with OSHA. Christina holds a master's degree from Johns Hopkins Bloomberg School of Public Health and a double major from Smith College in Neuroscience and Women and Gender Studies. of course, outside of work, Christina rows with the LGBTQ rowing team, the DC Strokes, and trains for the next marathon in Gardens. Great. Next up, we have May Navarra. May Navarra is a senior research assistant at the Gender Care Center at Boston Medical Center. I'm fortunate to work with May. Their research interests include transgender health, patient-centered care, and community-centered interventions. Currently, their studies focus on improving how we collect sexual orientation and gender identity data for electronic health medical records. They believe, of course, that people conducting the research should look like the population being studied, and May is proud to be part of the growing body of trans researchers in this field. So again, thank you everybody for joining. So as you can tell from everybody's brief introductions, they are the experts on sexual orientation, gender identity. But I think it'd be helpful to kind of lay the groundwork for people who may not be familiar with sexual orientation, gender identity, or SOGI, as we say for short. May, can you kind of give us just a brief overview of like what is SOGI in terms of when we keep using that acronym?
So SOGI is, it is sexual orientation and gender identity. But it also encompasses things like sex assigned at birth, intersex or difference in sexual development status, and I already say I said gender identity already. Pronouns, legal sex. These are the SOGI markers that you would typically see in electronic medical records.
Exactly. And there's also additional components that sometimes get wrapped in depending on research questions around gender expression as well. But we often use the SOGI, SOGI for shorthand. Kellen.
Yeah, just to piggyback a little bit on May's excellent overview, there are a number of different constructs that go into these concepts that we think of as sexual orientation, gender identity. They might look like singular variables, but there's actually quite a bit underneath each one of them. The sexual orientation, the concept of sexual orientation, for example, is widely understood to be comprised of 3 different components: identity, behavior, and attraction. This is very important in our public health world, where people may hold an identity but behave in a way that we wouldn't necessarily expect to align with that identity. So that is why breaking down sexual orientation into those components of identity, for example, do you describe your sexual orientation as gay, as straight, as bisexual, as queer, as another term? Behavior and attraction. And attraction in particular is important for young people as well as for folks throughout the lifespan, when we're trying to better understand the ways in which people form their identities and the ways in which they express elements of personhood, such as sexual orientation. On the gender side, there is, of course, gender identity and gender expression. Gender identity just being how do you describe your gender as a man, as a woman, as somebody who is non-binary or agender. There are also terms that are coming into increasing use around this concept of gender and better understanding what we mean for trans folks in particular. Gender modality is a term that is increasingly in use, and it describes whether someone identifies as transgender or as cisgender. And according to the National Academies of Sciences, Engineering, and Medicine, that transgender group is comprised of all people whose gender is different from the sex that they were assigned at birth. So if someone was assigned female at birth, for example, but their gender identity is male or as a man, then that person's gender modality, we would describe them as a transgender person. So there's a lot that goes into these concepts or constructs of sexual orientation, gender identity, and intersex status. One thing that I want to emphasize, though, is that these are all demographic data. They, of course, have relevance in the healthcare setting, making sure that people can get access to the healthcare that they need. But fundamentally speaking, these are about fundamental aspects of personhood, fundamental aspects of who we are as people. So they are demographic variables, and they work in tandem with other demographic variables such as race, ethnicity, primary language, disability status, and others.
Thank you so much, Kellen. I think that's a great expansion on what May had mentioned as well. And I'm kind of curious, you mentioned something briefly as it relates to what's really important for younger folks, but I'm kind of curious, Christina, in your experience in CMS, can we use the same measures across the lifespan? Are we asking questions appropriately of all ages?
You know, there's still a lot of evolving research on this topic. Drawing on the fields of psychology, many of us know that the research shows that folks at a very young age have a sense of who they are and are willing to tell people who they are as far as gender identity. Sometimes, also in the case of sexual orientation, in terms of attraction. But there are some challenges around comprehension for terminology. And so having the language to be able to self identify or self report on some stuff ends up being more challenging in a number of ways for younger folks. There is a little bit more coalescing around sort of like age 13 to 15 being a really good time where you can use the same questions you would use for adults for asking about sexual orientation and gender identity. But in terms of other better, more nuanced measures, I think there's still a lot of work to be done. I would also just add that there are many situations where demographic information is asked about on behalf of someone else, like in the case of a parent or guardian filling out information for a young person. And in those situations, proxy reporting is what we call that. We don't necessarily know if those questions would be valid because there has to be a lot of trust. You have to really know the young person. Sometimes that may not be there in those relationships. So that data might not be as reliable as self report.
Excellent. Thank you. Colin?
One other quick thing that I would note in relation to age, sometimes it's about young people not understanding the constructs or not understanding the questions. Oftentimes, though, it has to do with older folks, perhaps the folks asking the questions, who are not as familiar with some emerging concepts and identities around sexual orientation and gender identity, in particular for young people. So that goes back to the importance of thinking both about the population that you're working with. Is it primarily comprised of LGBTQI plus people, in which case you might have emerging terms that are more popular or more prevalent among young people, as opposed to a more general population where you might have a larger group of folks who are more familiar with the basic, let's call them basic identities that we tend to find grouped under that LGBT umbrella: lesbian, gay, bisexual, heterosexual, or straight. So it's a balance between making sure that you are asking questions that are comprehensive so that everyone has an opportunity to see an answer option that really looks like them or sounds like the term that they would use to describe themselves, while also making sure that the questions and their answer options are comprehensible to the larger population that you're working with.
And I feel like something that both you and Christina have touched on is this notion of making sure that we're asking questions in a way that are understood, making sure that we're using terminology that is understood. And so, May, I'm kind of curious from your experience, essentially pushing forward some qualitative research around how we are asking these questions. How does SOGI and how do broader LGBTQI plus identities and the terminology for that, how does that fit into our understanding of health literacy? And do we need to make adjustments based on health literacy?
I'm sorry, can you repeat the last part again?
Yeah, like how is SOGI, how do we need to account for SOGI with regards to health literacy in terms of people's understanding of their health, of basic terminology and basic healthcare concepts?
Right. So for terminology, I mean for certain things like sexual orientation, like these things are important to know in terms and like things like sex assigned at birth and knowing what that means. It's important to know for things that are like medically pertinent for the patient to be able to communicate with their provider and for the provider to know how to effectively care for their patient as a whole person. Not only in terms of like behaviors, um, uh, and like risk factors, but also knowing what your patient's support system or family structure could look like, because that is also important to know in treating your patient as a whole person. Um,
Yeah, I think that's good. And what I want to also double check about is when you've done interviews with folks from different backgrounds, what have you noticed in terms of people's understanding of just the how we're asking the question right now?
so it's really interesting for I have interviewed both LGBTQ people and also people who are like cisgender and straight. Um, and for the folks that are not LGBTQ identified, um, they have been, for the most part, very like well-meaning and very um, uh, they've had the attitude of like, I might not understand what all of these terms are under this question, but I understand that it's there for someone. Um, and I can like respect that it's being asked for someone that's not me. Um, uh, I've also found that an interesting thing when I'm looking at people who are LGBTQ identified in the way that these questions are asked. Um, an interesting thing that I found is that not just because you may be LGBTQ identified, that doesn't mean that you know all of the terms that are presented to you in a question. Um, and so for both LGBTQ folks and non-LGBTQ folks, their feedback was, I would really appreciate some definitions or some examples, some explanation of what these different words mean.
Thank you so much. And again, that's also within our experience within Boston and the Boston area. So typically from what is often perhaps incorrectly stereotyped as a highly educated, as if, and honestly, education alone doesn't give you the access to all this terminology as well. So again, recognizing that when we are asking these questions, we really need to make sure that we are explaining what we're actually asking. What do all the terms mean? I am of a generation where there are terms that are new since I came out, so I need to stay up to snuff. I appreciate that May, as my younger colleague, keeps me on point. Um, Christina, I'm kind of curious, given what May was sharing around terminology and such, what has been your experience around how we need to consider language, if we need to think about issues around non-English language proficiency when we're asking SOGI data, SOGI, either in the clinical setting or in population surveys and so forth?
Yeah, absolutely. So I think one of the most interesting things, and May, you did such a great job of like highlighting this and making me reflect on how most of the research that we have currently existing about how people understand questions on sexual orientation and gender identity comes from survey methodology. It does not come from necessarily a patient first or person first approach. And in survey methodology, having additional definitions for things within a survey is very frowned upon. And so we end up not necessarily knowing, for instance, in a large population survey, whether somebody's selecting something because it's the only one that they know, or because that's actually reflective of their identities, right? And that actually comes in very strongly when we have translations into languages other than English. The US tends to try to function as an English speaking country, but we know that there are many, many, many languages. And that's exampled, I think one of the best examples I like is that the US Census is translated into something like 27 different languages to make sure that there is an accessible way for all residents within the US to be able to respond to it. And so when we look at that diversity of language, we encounter some more challenges because sexual orientation and gender identities are culturally specific also. There is going to be a difference between how somebody of Hindu Indian descent might refer to their gender identity than somebody who grew up in Germany, for instance. Um, if we think about indigenous populations, the terminology around the two-spirit communities is very different and far more dynamic than many of the Western language terms that we use for describing sexual orientations and gender identities. So, as we consider how we make these questions and response options, especially culturally appropriate, culturally sensitive, and relevant to as many people as possible, it's sort of a double impact on the health literacy, not just about whether people understand those English terms and the English translation or constructs around gender identity and sexual orientation, but also how they're understanding them from their direct and specific cultural background.
I think I would also just add here that one, I think we're presenting the complications of collecting sexual orientation, gender identity, all the components, and recognizing that there are many ways that people have dedicated decades of doing research around validating a lot of the existing measures. But it's one of those things where all data measures are really imperfect, and that we are always striving for people understanding and being more informed, ideally, by the folks we're actually studying. And this kind of brings me up in terms of we don't know what we don't know until we're faced with it. And I was recently in Canada for a conference, and I naively was just unaware, for example, of the notion of around how we address non-binary identities in other languages. For example, French, which does have a non-binary option, but then you have to still discuss, are you talking about masculine or feminine adjectives or other terminology? So there's like a much larger way of thinking about non-binary identities that, again, from an English hegemonic perspective, I was unaware of.
You
So
should
again,
talk to me next time about transitioning in Moscow, where Russian is an extraordinarily gendered language, not only your nouns and adjectives, but also your past tense verbs. And there are 3 genders in Russian: masculine, feminine, and neuter, similar to German for those who are familiar with it. So there is quite a lot that goes into, yes, both self-conception in a variety of languages and then the interchange between different languages and different cultural backgrounds.
I think there should be a highlight. Oh, so go ahead, Christina.
I was also going to add that at 2 that I know of, Japanese and Hungarian, do not have gendered language at all. And so it is quite surprising. I was visiting in Hungary, and my friend kept like talking to somebody about his friend visiting from America, and they were all shocked when I showed up and was a woman, and they were like, because they had no idea, like it just doesn't exist, and there's no framework unless you specifically like go above and beyond to describe that a person has a gender. So,
I think for our attendees, I know a lot of our research can often be US based, but I think it's worth recognizing that there's unique challenges when trying to do broadly LGBTQ or honestly all population research. You should be, as Colin noted, this is demographics. You should be including SOGI in all research, but the global perspective around including these questions is complicated by us making sure we are being appropriate and using appropriate terminology and language of where we're trying to survey. But kind of circling back and thinking a little bit about the US context, I'm kind of curious, Christina, Callan, May, I think you've also had this experience. Can you tell me a little bit more about people's refusal of answering these questions? Is there concern about, if we do a survey, are people going to drop off? Are people going to not answer questions around sexual orientation or gender identity? Anybody feel free to jump in.
yeah, I'm happy to start off. Some of the research that has been done in the federal sphere indicates that people, by and large, are far more comfortable sharing responses for their sexual orientation and gender identity than they are sharing their household income, for instance. When we think about really sensitive topics, sharing information on large anonymous surveys, not particularly threatening for folks. In a lot of contexts, there's a lot of literature to support that in healthcare settings, part of the anxiety is actually from the care provider's side about asking those kinds of questions. Um, I like giving the anecdote from my personal life because I use my mom as a test subject for a lot of the work that I do. Um, I like to think of my mom as being sort of expansive in a lot of ways, and she self describes herself as queer. And when I ask her what that means to her, she says, "It's none of your damn business." So I think there's kind of a limit and there's also a context for any of these situations, and people have varying comfort levels. So, one of the ways that we can start to address that is by building rapport in these settings, particularly in healthcare settings. That can help mitigate some language or literacy issues, particularly if somebody feels welcomed and supported and not threatened in that situation.
Yeah, just to add on from some of the research that we did, I was a consensus study member at the National Academy of Sciences for a study that came out in 2022 about measuring sex, sexual orientation, and gender identity. And one of the things that we looked into was survey breakoff. And as Christina noted, we looked at that both in the US context as well as international contexts. Some of the countries, speaking of Canada, that are ahead of us in terms of adding these variables to surveys such as their national census, finding that breakoff rates were extraordinarily low, that people are generally more than happy to answer these questions. That said, there are a couple of themes that I heard in what Christina was saying that I want to pull out and kind of double down on. One of them is the trust element. This is not new for all of us in healthcare. I think we're all increasingly aware of the conversation around trust and mistrust, medical mistrust, and the ways that medical mistrust is a completely rational response to historical and, in many cases, ongoing oppression and mistreatment. So it is not something that people can be cured of. It is not something that we need to, kind of treat people and then they'll be fine. It is a matter of really putting in the time and energy to understand historical and ongoing barriers, to build interpersonal relationships, to build systems and structures and processes that are inclusive. For example, by making it possible for people to share sexual orientation, gender identity, variations in sex characteristics in electronic medical records, in health surveys, in other forms of data collection. One of the other elements that we really emphasize beyond the point that all data collection should be voluntary. So there are obviously some surveys that well, I guess not obviously, there are some surveys to which you have to respond, the US Census, for example. But when we're talking about sexual orientation and gender identity, as well as variations in sex characteristics, these are data points that should always be voluntary. And in general, responding to demographic questions of any kind, race, ethnicity, disability status, etc., these are all voluntary questions, such that no one's ability to access a benefit or participate in a program or to generally have their voice and opinions heard, none of that is conditional upon providing any particular response to any particular question. But the other thing that we do emphasize is, when possible, including an open-ended response option, such that people can define these elements of their identity in their own words. That is something that's, can be difficult to operationalize in some surveys or in electronic medical records, but it is a strong recommendation from the national academies, and it's something that NIH has been taking up quite strongly as well, is that you need to have, going back to that balance of having enough response options that folks can recognize themselves while not overwhelming others for whom those response options might not be pertinent, actually including an open-ended response option to allow people to identify these elements of their identity in their own words.
To agree with both of you, in my research, looking at patient perspectives, absolutely with the medical mistrust, and absolutely with the building rapport. I have found that in terms of helping to build rapport, the patients that I've interviewed have said that they would appreciate like having the questions, SOGI data collections, be prefaced with like, what is the purpose of this data collection, right? Like, they want to know, is this medically relevant for the care that I'm about to receive? I remember from the interviews that I did, there was this one participant who said, my dentist doesn't need to know that I'm bisexual. That has nothing to do with the state of my teeth. And yeah, so like, is this data collection medically relevant? um, or, they would also like to appreciate, like, they also know that, uh, this is, as Kellen has been saying, like, this is also, just another form of demographics. So is this being collected for research purposes, so that we could see what are the health outcomes of this specific population in this hospital system? Like some transparency in knowing, you know, what is this very personal information that I'm like surrendering? What is it being used for? Um, uh, that I think, could help with some folks being hesitant to answer these questions.
Yeah, it is widely recommended throughout healthcare and sort of throughout different types of data collection that you explain what you're going to do with these data, what kinds of protections apply to them. That's as true for race and ethnicity. As Christina was noting, there's a very high rate of non-response to questions about disability. On surveys, there's high non-response to questions about income. In healthcare settings, there's often a high rate of non-response to race and ethnicity because people quite rightly want to know, well, what are you going to do with this information? And helping people have that kind of that kind of touch point of this is what I'm going to do with these data. This is why I'm asking. It has to do with making sure you get the care you need. That's particularly relevant with regard to gender identity, for example, although it's also relevant to other demographics. And of course, it's important on a population level so that you can track differential access, differential quality, and differential outcomes for populations as a whole, making sure that people individually and at the community level get the care that they need.
Absolutely. I feel like you've all answered one of the questions that we had in the Q&A already in terms of it is necessary. It's really important to explain why are you asking questions, how are you using the data, and what's the purpose of that. There was an additional corollary to the Q&A in terms of there may be other settings where it's not appropriate, but I would highlight that when the reason can be explained and it can be used to assess a population, it's kind of necessary. We're starting to include more sexual orientation and gender identity questions in health workforce questions, in membership organizations. The American Bar Association includes SOGI as part of their membership profiles. The American Medical Association does now. All volunteer and all used to see what's going on at the membership level. And a publication is coming out that shows that when we include SOGI data in the health workforce, we actually are identifying higher rates of burnout among physicians, so among LGBTQ physicians. So without the data, without those questions, we can't identify problems that are potentially intervenable. So I will mark that. Hopefully that question's been answered fully in the Q&A. I'd be kind of curious, anybody if can jump in on this in terms of how do we make surveys, research questions, clinical encounters more welcoming in a standard way? And that's my kind of way of saying, how do we essentially remove gendered language while still being understandable for folks? I think a lot of people are still used to being asked like, who's your husband, who's your wife, kind of thing. And anybody feel free to jump in on any of those contexts.
So we actually have done a lot of work on that at NIH as well. The NIH Style Guide has recommendations for degendering some common things like talking about pregnant people instead of pregnant women. And, we're working with a lot of the institutes and centers across NIH to ensure in any of their human subjects research, they have gender neutral or degendered language in their protocols so that it's appropriate for anyone to participate. Some of that language can feel insensitive and stigmatizing in a way that would prevent people from participating. And I think we know that historically, LGBTQ folks have always participated in research in some way or another. We just haven't been able to identify them necessarily when we aren't collecting these data. And we would want to make sure that we do what we can to affirm folks. getting rid of like the he/she stuff and just using they or them appropriately in writing is also really, really useful and linguistically appropriate. No one has any trouble understanding when you make that switch grammatically. So I see we actually have a question about reporting on NIH tables for researcher participation. We are currently in the process of working to address that. They do still only have a binary-ish option. They're actually reported in male, female, and non-reported or other. So there is sort of a third option. It's not the best, but hopefully that will be something that will be coming out in the near future as well.
I think just on that point, I will highlight that JAMA's style guide recently presented draft language and recommendations around sexual orientation, gender identity, and how that plays a role in reporting in journals and such. So keep an eye out for how this is, again, evolving within the research enterprise.
Can I just ask, I'm sorry, Christina, that you said there's a third option, but I don't see that on the NIH submission side.
When people leave it blank, or do not, or when like the number of participants does not sum to the same as the reported M and F, there is a third column that's created on the back end.
I'm going to try it.
Okay. Uh-oh.
Yes, a major consideration for NIH, the sex as a biological variable policy and the inclusion tables to make sure that transgender and intersex people are not being excluded and to make sure that we are not forcing people into tiny, 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 uncomfortable and inaccurate boxes when we are trying to describe their inclusion in clinical trials. This is particularly important looking at, for example, the efforts at NIH, as well as the new FDA requirements about diversity in clinical trials, making sure that our clinical trials infrastructure is including people of different sexual orientations, genders, gender identity, and intersex statuses, and making sure that our the research infrastructure around that actually facilitates and allows that inclusion.
Excellent. Be kind of curious, and kind of you talked about this a little bit. What are some examples at a population level where SOGI has revealed something that we didn't anticipate? Or maybe give us some examples like water is wet, in terms of the research has showed us what we kind of knew collectively as a community, but we needed to really generate data.
That is often a position that I think many of us who do work in LGBTQI plus health find ourselves in. On the one hand, there's a lot to discover because LGBTQI plus populations have been systematically excluded from a lot of health research, a lot of surveys from EMRs, other clinical data collections, et cetera. And at the same time, a lot of the disparities affecting LGBTQI plus populations, again, with regard to access, quality, and outcomes at both the individual and population level, are well known. So there is quite a bit of research that we are still having to do that, to use your phrase, Carl, the water is wet research, the sky is blue, demonstrating that, in fact, sexual orientation and gender identity and intersex status are important. And they're not just important for LGBTQI plus people. Everyone has a sexual orientation. Everyone has a gender. Everyone has a gender identity. And all of these things impact our lives in different ways, sometimes because we're transgender, but also sometimes, for example, because we're cisgender women, sometimes because we're queer or bisexual men, but also sometimes because we're straight men. There are a lot of ways in which these variables really do come into play for all kinds of populations and all kinds of considerations and research questions. So it is, we're at an interesting point now where we're starting to see these variables added to more and more studies, more and more surveys. We're getting more and more data that, again, confirm a lot of what we know about the problems that exist. So some of those that I would highlight, there's a lot of good research, for example, that comes from the Behavioral Risk Factor Surveillance System. This is a partnership between the states and the CDC to field the BRIFIS, the largest ongoing health survey in the world the BRIFIS has had the opportunity for states and localities or jurisdictions such as Washington, D.C. that are not yet states, had the ability to add sexual orientation and gender identity questions. And then those data are pooled with the other states that are using those questions. And that has allowed for a really interesting sample of about 30 to 40 states in any given year using the sexual orientation and gender identity measures on their BRIFIS and identifying disparities, for example, in access to preventive care. Transgender people, for instance, being less likely to get cancer screening. They have identified disparities in cardiovascular disease. They have identified disparities in, for instance, sleep, in mental health, and a lot of that is related, which is one of the areas where we're moving beyond a little bit the water is wet research to look at, well, why and what does that mean? Understanding the role of quote unquote minority stress, this experience of being treated, of having yourself, your life, your family, your identity being treated as a problem by social structures that are designed for compliance and control. So when we look at, for example, the exposures of structural racism, of anti-LGBTQ bias that's baked into law, we are starting to see research coming back out of some of these large national surveys, as well as research studies funded by NIH, for instance, that are showing the ways in which the exposures that LGBTQI plus people move through in their day-to-day lives do have real health impacts. And so I think that that is an important, we're going from the descriptive assessments, what are the gaps, to a little bit more upstream. Where do those gaps come from? For example, the minority stress framework, which helps us understand that. And then the next step beyond that is intervention research. So now that we know what the problem is and what's causing it, what do we do to stop it? What do we do to fix it? And so there's a lot of really interesting research, again, happening, supported by NIH and others, that's looking at how do we best support LGBTQI plus people in living safe and healthy lives in safe and healthy communities.
Thank you. I have a few more questions I want to ask, but I want to remind people, if you have questions of your own, please feel free to put them in the Q&A. We'll be using that to ask our panelists, again, opening up a dialogue around this as well. But I want, again, question for everyone. May, I kind of want to start with you, is given in your experience, what have you seen in terms of research that is done well in terms of how it engages community members, people who are actually part of the populations you're trying to understand?
Well, it definitely helps to have it. Well, if the population that you're looking at is trans folks, it definitely helps to have a trans researcher. um, a trans researcher, like at every step of the way of the study development, but especially in recruitment. I'm a big believer in community-driven research and community-driven interventions. And so this is my not so subtle way of saying, everyone, please hire more trans people. Thank you. But yeah, I mean, in terms of things that I've seen done well, I would definitely say, yeah, having the population you're studying be part of your team, have recruitment be far and wide, and also, I mean, a community advisory board would be really swell. Those are a lot of work to keep up. But, you know, not like, it doesn't feel good as a researcher to just dip your toes into a community, do your little research, and then pop out. And especially if you are engaging with marginalized populations, please pay them for their time. Please pay them well.
We have a So we do a lot of thinking about this question. The organization that I run, Whitman Walker Institute, is by happenstance queer and trans led. So to echo May's point, employ queer and trans people, put them in charge. That said, that also brings us to a question of the pathways to these kinds of roles. Workforce development. There is quite a bit of research demonstrating that the pathway from secondary education up through postgraduate training in the sciences and STEM fields is quite leaky or quite easily lost for many LGBTQI plus people, particularly folks of color, particularly folks who are coming from other backgrounds that are traditionally underrepresented. I'm using air quotes here because it makes it sound traditional. It makes it sound like, well, it just was. Of course, it's manifestations of structural racism and other forms of oppression that have kept people out of these types of careers, out of these opportunities for career development. So really being intentional about building the workforce in LGBTQI plus health, whether that's in clinical practice, whether that's in public health and community oriented programs, or whether that is in the health science research workforce. Being intentional about that, making sure that you are looking for opportunities to employ LGBTQI plus people directly, again, either as folks who are in roles where we are, helping to lead this from a professional standpoint, and or from the perspective of folks in community who also have expertise. I think that's a distinction that we too often end up making is there's the folks with the professional expertise and the folks with the personal expertise, and that never those two shall meet, and that there's always the one that's a little bit lower than the other. And that is absolutely not true. There are all kinds of ways of having expertise, and having a piece of paper with your name on it, maybe a little bit of Latin, does absolutely nothing to confer upon you expertise necessarily in how LGBTQI plus people live their lives, what kind of research is important to them, how they want the findings disseminated, what they want done with the findings. So really being deeply engaged in community, recognizing the many, many folks who wear multiple hats as community leaders, as researchers, as engaged participants, recognizing all of those different forms of expertise. I'll wrap up with just a handful of other quick things. One is recognizing the power relationships that exist in training as well as in doing research. And in particular, we're hearing, you often hear researchers talking about concepts or frameworks like intersectionality and kind of using that to mean, well, folks have multiple identities. That's not what intersectionality is. It is a power analysis. It means looking at where has power historically been held, where is it still being held, and how is it being shared, or as Frederick Douglass noted, taken because it must be taken. It is never, almost never, freely given. So acknowledging that research, science, medical practice, these are all powerful institutions. And it is incumbent on representatives of those institutions to recognize that power and to do the work of dismantling the one-way hegemony that has so often been at play in the relationships between researchers and the researched. The last two things that I'll say, in terms of community engagement, I would recommend looking at studies like the US Transgender Survey. It just came out, the Early Insights Report. You can find it by Googling the 2022 US Trans Survey, and you can see there a great deal of work that went into engaging with more than 92,000 transgender and gender expansive folks across the country to fill out an almost 600 question survey. So there was a great deal of community trust, rapport that was built there, belief that these data would be not just gathered, but used. And finally, on the 25th, we will be coming out with a publication from the Roundtable on Precision Health at the National Academies that is focused on genomics. We did a roundtable in July of this year looking at community engagement in genomics, which is a pretty tough area to do community engagement in because of mistrust and, sort of just in terms of complicated, somewhat arcane topics. So that we are hopeful that this publication will be useful, not just in the field of genomics, but for folks more broadly in the sciences, looking at engaging communities throughout the research process and in multiple different areas of study.
Christina, please.
I was just going to springboard off of some of Kellen's highlights to share some of the foundational work that has been happening in the federal government. Of course, the federal evidence agenda that came out in 2023, and I'll go ahead and pop these in the chat for folks as well, along with the HHS SOGI Data Action Plan, of course, outlining goals and objectives for all of the components across the department to improve their collection of SOGI data. These two publications have been really important in terms of having conversations with folks across the department, helping to educate folks, and also get individual programs to move towards being more inclusive in a number of different ways. So they're both available, delightful reading material for an evening in. And we hope that we will be doing a lot more in the future with them. Just to touch on the critical component of community advisory boards, where I work in the Sexual and Gender Minority Research Office at NIH, we also have an advisory board of subject matter experts, and there are many diverse folks, including trans folks, intersex health experts as well, who have been members of that advisory committee, and we really, truly could not do the work that we do without having those community members and subject matter experts providing that support and guidance for our offices.
Excellent. And I think I will just put in a little bit my 2 cents. It's important to recognize that if you are being brought in as it relates to your identity, to make sure work with the researchers to make sure you're not being tokenized. There's been many situations where I have to explain to folks, like, just because I'm a gay man doesn't mean I know all gay men or that I know all perspectives of gay men. And that also means the rest of the acronym. So I need to make sure that I also learn about that if I'm being brought in as a broader expert as well. Expertise can be derived from your experience, but not your experience alone. It's one of those situations where we have to recognize our own limitations. And I think a little bit of a corollary to that is noting that you not being part of the community does not make you objective. It has that you bring your own biases to the research, no matter who you are and what populations you're studying. You are not objective by virtue of not being part of the community. So I think it's important to highlight that. We were planning to be done at 5. I know we have technically until 5:30, but I want to make sure if people have additional questions, please answer now. Otherwise, I want to make sure the panel has a chance to kind of share any final thoughts. Oh, we got a Q&A. How best to approach with humility LGBTQ plus community members to review surveys and data collection instruments to ask for review to ensure data collection materials are inclusive. Understanding that an agency should do their best first to update materials using best practices. I totally agree. Should agencies route through an advisory board? Christina, I'm hearing agencies and I'm looking at you first.
Yeah, absolutely. So I would say that depending what your agency is, whether you are with a state or territory health department or another federal agency, the SGMRO is the only office in the federal government that is specifically dedicated to providing technical assistance and support on sexual orientation, gender identity, and sex characteristics questions and work. Before you reach out to individual community members, reach out to the other subject matter experts who provide this kind of technical assistance as part of our paid jobs. I get to be gay for pay. We also have a lot of great resources with the Federal Committee on Statistical Methodology. We actually have an interest group that anyone is welcome to join, as well as a smaller subcommittee that is more focused on developing specific researcher tools. I will Kellen, can you grab the FCSM website? Not the old one, the new one. Thank you. And that's a really great resource. We actually have, I think it's a 1 or 2 pager that's like why this data is really important and how to use it appropriately, as well as 3 older papers, much more outdate than the 2022 National Academies report that Kellen was talking about earlier. But the FCSM site does have a lot of resources. I'll go ahead and put my email in the chat as well. Folks are welcome to reach out to me. I provide a lot of technical assistance for states, territories, other folks across the federal government around measurement and how to design questions for a variety of different purposes.
Actually take that opportunity. If the other panelists feel comfortable, feel free to include your email that you'd like to share with folks. If you're ready, willing, and able to answer any kind of follow-up questions. Naturally, all three of these folks, if I don't work with them directly, are people I definitely ping all the time. And much like Christina, I'm also gay for pay in terms of this is like our job, and I definitely had to provide expert perspective. But again, recognizing my own limitations of what I do know and what's the actual questions and who else should be connected and brought in. If you have that one person at work, you shouldn't keep bugging just that one person. Great that they're helping, but I'm sure that there are many other folks that they can connect you to. Any additional questions? Okay, I want to take an opportunity and have people kind of formulate their final thoughts. If any last things they'd want to share with this group. We got Michael coming off mute.
No, I just wanted to thank you. I wanted to thank you. I didn't realize you were going to have another round, but final thoughts and questions would be fine. I just was just being grateful for the conversation. Maybe if you're going to have a round of final thoughts, but maybe if people could include or consider the specific angle of health literacy as well in what needs to happen next. But there's still lots of water is wet stuff to be done, but things that you would love to see happen, that would be great to hear.
I will take this from a perspective of a Quaker. Whoever the spirit moves first, feel free to jump in with their final thoughts.
I guess I feel the spirit moving through me. I'm an Episcopalian, but don't judge. I think the thing that I would say that dovetails with conversations around health literacy is just ask the question. Ask the questions. They're not as scary as we have been led to think. They're not as confusing as we have been led to think. It doesn't mean we don't need to be thoughtful, as Christina and May have outlined, looking at different levels of language and culture and where are people coming from and how do we make sure that we're meeting them where they're at. But the fundamental principle that I work from is ask the question. If people don't want to respond or they can't respond, then those are issues that you can work with and you can solve for going forward. But you miss 100%. I'm going to use a sports metaphor. You miss 100% of the shots you don't take. So take the shot, ask the question, and work from there to make sure that you're getting the right information that you need to serve people and get them access to whatever it is that they need.
I will iterate what many biostatisticians have said before me, which is if you're not counted, you don't count. And so with reiterating everything that Kellen has said with the demographics, like the importance of asking these questions for the demographics and, looking at our health outcomes at a population and community level, it's hard to see what's going on with LGBTQ populations if we can't see them. So yeah, please ask the questions.
I can't believe after knowing you for so many years, Carl, that it was today that I realized we had Quakerism in common also. Clearly just talking about too many queer things to get around to like other big topics like religion. I think what brought me into LGBTQ health in the first place was a focus on cultural competence training and health literacy. And a large part of that was because I knew people who would share with me that they had gone to their doctor's office and their doctor had just assumed that they were straight and that they might be having straight sex, and that their doctor did not understand when they said, no, I don't need to worry about pregnancy prevention. Trust me, I have the best pregnancy prevention, not sleeping with men. um, and that was really the first thing that had drawn me into what is a continually evolving and far more complex and nuanced area. Um, I'm originally from New Mexico, and my grandmother is Hispanic. English is her second language, and I realized that when she goes into the doctor's office, if she does not have someone there checking in every step of the way to make sure that she understands what is happening in that conversation with her doctor, she will just nod to anything because for her, the doctor is somebody you respect. So if the doctor tells you that you have huevos viejos instead of huesos viejos, grandma will nod and think that that's the reason her knees are hurting. And that's going to be an error that can be perpetuated in any number of situations because who someone is and what body parts they have are really central to getting the care that they need. And if we aren't doing that, then are we really providing healthcare?
I want to thank everybody so much for being part of the panel. I want to thank our attendees for listening to us, for asking really thoughtful questions. We greatly appreciate that. And again, we've put resources in the chat so you know where we're talking about. And again, recognizing you do not need to reinvent the wheel. There's a lot of resources out there. There's definitely ways to iterate and make that wheel serve you, but don't have to start from scratch. And again, everybody's been very gracious to share their email. We are available to help you do this. I'm happy to help as well. We can do it as consultation, but also remember, pay people to do the work around this. We are experts. So again, thank you, everybody. I'll turn it over to Michael if you have any.
I didn't need to say anything else. I was just waving. Thank you, everybody.
Great. Thank you. Have a great rest of your day.